So thank you very much for the kind invitation. It's always a pleasure being here with all good friends. So my task today is to give you an overview about the current situation with TAVI and a glimpse into the future. Some of the information have already been mentioned in the previous talks, so this gives us a chance to go quickly across them. Just as a reminder, we are looking on 15 years back from the first TAVI ever done. And since the commercial release of the first TAVIs in Europe in 2007 and in the United States in 2012, you can see the graph. There has been a marked and a steep rise of the number of TAVIs and a relative decline in the numbers of open surgical valve replacement. If you look on the numbers today, we have almost 103,000 TAVIs being done in this year, which is a factor 3 increase within 5 years. And if you look into the prognosis from a financial point of view from the Credit Suisse, they are estimating a further 3-fold increase within the next 10 years to reach 330,000 TAVIs in the year of 2027. The industry has provided a very good support in this with the continuous development and efficiency of the TAVI devices provided. You can see the current TAVI devices available now on the market. The impact on the health resource utilization through introducing TAVI is enormous. If you look in comparison to surgical aortic valve replacement, you see a marked and significant decline in the procedure time, the median ICU stay, and the total hospital stay, which naturally transfers into cost effectiveness apart from the TAVI device prices themselves, which are definitely continuously going down. Looking from a cost effectiveness point of view, you can see that the transfemoral TAVI, but not the transapical TAVI, is a cost-effective procedure. This is simply because the transapical TAVI is still a cardiosurgical procedure which utilizes the health resources like open cardiac surgeries. The clinical evidence, the evolution of clinical evidence across the different risk categories of patients has been established in randomized trials from inoperable patients to high risk, intermediate, and low risk. And it's clear for inoperable patients that TAVI is superior to medical treatment in terms of mortality, no doubt about that. If you look to high surgical risk patients, TAVI is at least non-inferior, if not superior, to open heart surgery. Again, no doubt about that. And for low and intermediate risk, we now have evidence that TAVI is non-inferior or superior, but well noticed only for transfemoral procedures compared to surgical aortic valve replacement. A nice meta-analysis summarizing 4 randomized trials comparing TAVI to surgical aortic valve replacement show an overall significant advantage in mortality at 2 years for TAVI compared to surgical aortic valve replacement. Again, well noted, this advantage goes only to the less invasive procedures, meaning the transfemoral approaches, and not to the transthoracic. Transthoracic is a combined nomenclature for direct aortic and transapical. But overall, again, there is a mortality advantage for TAVI compared to surgical aortic valve replacement. That's why it was just logic that this year there have been a revision of the current guidelines, the American and the European. This is how the American guidelines have been revised. You can see now that TAVI is a good therapy for every patient category except the low surgical risk patients. The same can be seen in the European guidelines. And in the European guidelines, you can see the classification has differed a little bit. There is low surgical risk patient category and anything above, which is called increased surgical risk patients. And for any of these patients with the increased surgical risk patients, TAVI has found its place. I like the sentence in the publication: the favorable results of TAVI have been reproduced in multiple large-scale nationwide registries supporting the generalizability of outcomes observed in randomized trials, and this favors the use of TAVI over surgery in elderly patients and increased surgical risk. However, the decision of the heart team is mandatory. So there are some hints for the heart team to help in the decision making. From the same publication from the European guidelines, you can see there are clinical factors, there are anatomical and technical aspects and associated conditions which could favor the decision of the heart team in one of both directions, either for TAVI or for surgical aortic valve replacement. Let's look at some of them. So any patient equal or above 75, per definition, is a good candidate for TAVI or is legitimate to receive a TAVI, even if no other comorbidities, naturally, provided that he has good access for a transfemoral TAVI. On the other hand, just some hints, if you have associated heart conditions like a mitral valve, a tricuspid valve with each surgery, then naturally this goes into open heart surgery for a combined procedure. And if you have suspicion of endocarditis, this is a definite indication for surgery in order to eradicate the focus. So having seen these good results, what can we do better in order to expand the indication of TAVI? We still have some problems which we have to work on. We have some procedure-related problems. We know, it's no secret, that TAVI has a higher incidence of paravalvular leakages than surgical aortic valve replacement. And we also know that any paravalvular leakage which is more than mild is associated with a worse outcome compared to patients having either no paravalvular leakage or mild paravalvular leakage. So what has been done so far? Imaging tools have been massively improved in order to improve sizing of the device. The repositionability of the current devices helps in order to position the device in a perfect position and to mitigate the incidence of paravalvular leakage. The design of the current prostheses with the outer skirt or with the extended skirts, etc., have reduced massively the incidence of paravalvular leakage. You can see this in this slide. Two valves, the Edwards and the Medtronic, through the innovation, a reduction into the paravalvular leakage incidence. And with the recent innovation of the Medtronic valve, the Pro, you can see through the porcine pericardial wrap on the lower struts, a further decrease in the incidence of paravalvular leakage. Impressive from the first generation Medtronic devices, a paravalvular leakage incidence which is more than grade 2 in almost 20% of cases, and with the recent last US Evolute Pro study, 0%. The next problem we still have to tackle is the need for permanent pacemaker implantation, and this is again no secret that surgical valves require less permanent pacemaker implantation than TAVI. The good news is that there is no impact on mortality if the patient requires a permanent pacemaker implant. So patients with, without, or with a previous pacemaker are doing just fine. Several factors why this could happen. One important is the positioning of the device. So the retrievability of the devices have again contributed to the reduction of the pacemaker incidence. You can see the current incidence on the right lower corner of the slide. Almost 10% is the current incidence with the newer generations, and with the Edwards Centera, it has been described to be 5%. Moving down to lower risk patients, ongoing are 3 big randomized trials comparing TAVI to surgical aortic valve replacement. You can see the risk score, so less than 4% or even less than 3% STS risk, which is really low. You can see the devices being used, the sample size, and the endpoints all are enrolling right now. So we are looking forward to receive data about this group of patients. Durability of the TAVI prosthesis. First of that, specific anatomic conditions. I will go through this very quickly because Antonia has shown this to us. First, the main take-home message from this slide is that with the newer devices, you have an equal outcome whether you are putting the valve in a bicuspid or in a tricuspid anatomy. With the previous elderly devices, there was a different outcome, worse in the bicuspid anatomy than in the tricuspid anatomy. So with the innovation, also this problem is being approached and addressed well. The durability, TAVI versus surgical aortic valve replacement, the long-term hemodynamic data, you can see up to 5 years and up to 3 years that the gradients are as low as immediately after the operation. so the valves are durable, but we also know that there is a certain subject of patients which have the so-called valve hemodynamic deterioration. And this is defined by an increase of the mean gradient of 10 millimeters of mercury. This shows or declines valve hemodynamic correlation. The factors are diverse. Probably valve thrombosis is one of the most important factors for that, and valve thrombosis is either due to a surface factor from the prosthesis implanted, or hemostatic factors from the patient himself, or hemodynamic factors which are either from the patient, like low cardiac output, or from the device itself. So thrombosis of transcatheter aortic valves is an issue. You see there have been some efforts done to classify thrombosis of transcatheter aortic valves, either along the time frame or according to the certainty of the diagnosis. I will not go into the details of this classification, but let us focus on the clinical spectrum of these prosthetic valve thrombosis. It is either clinically apparent, meaning that the patient manifests either by a valve dysfunction, for example, new onset heart failure, or with a stroke, or with another systemic embolism, or it is subclinical meaning that it has been spotted on an imaging technique of the valve, but the patient is not aware of anything, is symptomless, or it is silent, that it is also noted as multiple defects in the brain. So subclinical leaflet thrombosis in bioprosthetic valves, you can see from this registry that it's definitely much higher with TAVI prosthesis than with surgical aortic valve bioprosthesis, 4% compared to 13%. This is how it looks like in imaging. And you can see from the same publication that when you have a patient manifesting with stroke or with TIA, and you look at his valve, you find that the majority of these patients, or a higher incidence of these patients, do have a limited leaflet mobility of the valve corresponding to a valve thrombosis, or one of the diagnostic criteria of valve thrombosis, compared to those who do not have this feature. So the point is that the main predictor factor has been found for valve thrombosis, the lack of oral anticoagulant at discharge. We're not talking about antiplatelets, but we're talking about oral anticoagulation. So you can see patients who did not have an oral anticoagulant at discharge have a much higher incidence of subclinical leaflet thrombosis compared to patients having any type of oral anticoagulant, particularly least when you are having a direct oral anticoagulant. That's why this is a subject of current investigation. You can see the ongoing trials for the proper, or investigating the proper antithrombotic treatment after TAVI. 3 big randomized trials. Just as an idea, the Galileo trial is randomizing either rivaroxaban and aspirin for 3 months, and then rivaroxaban ongoing, versus a dual antiplatelet therapy and aspirin ongoing. The Atlantis, if you have an indication for oral anticoagulant like atrial fibrillation, then you are randomized to 2 different types of oral anticoagulant, either a direct oral anticoagulant, apixaban, or the vitamin K antagonist. If you do not have an indication for oral anticoagulant, you are either taking apixaban versus an antiplatelet regimen. The third trial is also looking at patients who have another indication of oral anticoagulant, to randomize them to an oral anticoagulant plus clopidogrel versus an oral anticoagulant alone. If you do not have an indication, it is either aspirin or a dual antiplatelet therapy. So the message is clear. Till now, we do not have the clear answer what is the best regimen for our TAVI-treated patients after the procedure. Other clinical conditions, very quickly. This has been also mentioned, asymptomatic severe aortic stenosis. This is the design of the trial. So patients who have severe aortic stenosis but are asymptomatic, you put them on a treadmill test, and either it is abnormal, this is a clear indication for replacement, or it is negative, so meaning it's a normal stress test. There the randomization goes on either to early TAVI versus clinical follow-up. and the endpoint is an all-cause mortality, all strokes, and repeat hospitalization. We are very anxious to look at the results of this trial. The last trial I would like to show you is for patients with moderate aortic stenosis, not severe as in guidelines, plus congestive heart failure. It is an early relief of this moderate aortic stenosis through the study design you can see here. It is either TAVR plus optimal heart failure treatment or optimal heart failure treatment alone, and the primary endpoint is again all-cause death, disabling stroke, hospitalization for heart failure, or changing quality of life. I would like to end with this article, this message from a famous patient who has been asked about his experience in an open heart surgery versus a less invasive procedure in form of TAVI. You can read the last sentence that he simply says it is less debilitating than the open bypass heart surgery he previously had. There's simply no comparison. Thank you very much.